Good afternoon. Thanks, Dr. Shashi, for inviting me in this instruction course. And after a wonderful presentation by Dr. Rupal, I'll be talking about complications of LASIK. Now, LASIK is a relatively safe procedure, and but no procedure on earth, no surgical procedure is absolutely 100% safe, and there are risks of some complications, and that is true for LASIK as well. And since LASIK is a procedure in which you create a flap and then you do ablation, so you have intraoperative complications in the form of flap-related complications and ablation-related complications, and in the post-operative period you can have some other complications. So first of all, I would like to talk to you about the flap-related complications. The flap-related complications can be flap buttonhole, thin flap, irregular flap, incomplete flap, free cap. Now, flap buttonhole means you create an opening like this in the flap. So this flap is like a donut because you have a central opening, and if it is so, then you have to, as you can see, this part remained attached. So there was a donut-shaped flap. So the flap has to be reposited, and we have to wait for 3 months' time at least to do a recut. Now, if you are doing a recut, then it's always better to go deeper and go larger so that you incorporate that area, or you can do a surface ablation in the form of PRK. Now, if you have an incomplete flap, then that incomplete flap can be because of microkeratome jamming, which includes motor jamming, suction loss. Sometimes, you have the drapes or lashes coming in between, and in between the moving microkeratome, and that stops. Sometimes the microkeratome or the suction ring is not cleaned properly. There are salts in it, and that obstructs the movement, and that results in jamming. Although it's not very common, but it can happen, and it has happened to many people. And if you have an incomplete flap, then you have to decide based on the size of the flap that you have created. Now, if you have gone up to here, nearly here, this was the intended area of a hinge. Now, if you are almost here, then you can just cover the hinge and go ahead with the LASIK. So you can just cover it so that you don't hit the hinge. There is no ablation of the hinge, and then you can go ahead with the LASIK. But if you are somewhere here, then you can do a lamellar dissection in the same plane, and then you can go ahead with LASIK. But if you are somewhere here and the flap incomplete from the middle and even beyond, then you have to reposit the flap. Again, once you have reposited, whether it's a buttonhole or anything, you have to wait for 3 months, and once again the same policy, try to go deeper and bigger. You can have a dislocated flap or dislodged flap, because sometimes while you are just taking out the speculum, the patient squeezes, and then what happens with the, because of the speculum or anything, any instrument, the flap gets dislodged, and you may not see that. Sometimes what happens that post-LASIK, a patient undergoes a vitrectomy surgery, and because of any reason, because of a retinal detachment, a VR surgery, and epithelial debridement is done. If the surgeon has not been informed that the patient has undergone a LASIK surgery, then many times the surgeons are quite ruthless, with due respect to all the VR surgeons, but if you don't inform the VR surgeon, then sometimes it happens that the flap can get dislodged because the VR surgeon many times removes the epithelium to have better clarity. So if that is the case, if there is any dislodgement, if you immediately after LASIK, you should examine the patient on slit lamp. If there is any dislodgement, once again take the patient on the table, relift the flap, refloat it, and deposit it. The flap will be in position. Just take care that it doesn't happen again. Now, free caps can be seen in flat corneas. If you have a flat cornea, then many times the microkeratome moves completely, and before it reaches the area of hinge, it has done the full circle, so you have a free cap. Now, if sometimes what happens is the free cap is lost because the surgeon does not, does not see that the flap is a free cap, and the surgeon feels sometimes it falls down, sometimes it goes somewhere. It has been reported in literature that the cap was lost. Now, if it's lost, you don't know how much flattening it has done, so it's better you should wait for the surface to epithelialize, do a refraction later and see how much correction you require, whether hyperopic or myopic. But if the flap is retrieved, if it's there, then you can go ahead with the laser, reposit the flap, dry the area nicely on the edges, wait for 2 to 3 minutes for the flap to stick nicely, put a bandage contact lens, and then you can send the patient. It will remain stuck. Now, we have this, I was talking about the microkeratome flaps, but we can also have incomplete flap in a femtosecond LASIK when we are trying that. And again, in a flat keratometry, you can have that. So the decision depends on the stage of the lamellar cut when the suction loss had occurred. Now, when suction loss occurs during the raster stage, before initiating the side cut, then you can do the entire raster with the same diameter, and just you have to disable the pocket because you create the pocket before. So that has to be disabled. But if the suction loss occurs at the time of side cut or before side cut, then what you can do is that you can skip the raster stage, do a side cut, but within that area. So it should be slightly smaller so that you can lift a smaller flap. Vertical gas breakthrough, although it's extremely uncommon, but it has happened, and it is sort of a counterpart of buttonhole with microkeratome. What happens that if there's a very thin flap, or if the gas venting is ineffective, and of course the flap is also very, very thin, sometimes what happens that there's a vertical gas breakthrough, and that results in buttonhole, and you do the same, you reposit it and wait for some time, wait for a couple of months and do it again. Sometimes while doing a femto LASIK, bubbles go into the anterior chamber through the Schlemm's canal. In that case, some people have still done, after dilating the pupil and using the tracker, some people have reported that they have put the tracker off. It's always better to let the bubble absorb and do it later. Coming to flap stria. Now, flap stria can be micro stria, which are small strias, or it can be large stria. Now the management again depends whether it's a small stria not causing any visual problem. In that case, you can just follow up the patient, because if there is no visual problem and there is no refractive problem, no cylinder, no visual complaints, you can go ahead and just follow up the patient. But if you have a large flap stria like this, wherein you have a dislodgement of the flap as well, in that case, you have to, lift the flap and iron it on both sides of the flap, do an epithelial debridement, and then reposit the flap. Now, if the flap stria has been dealt, these micro stria has been dealt early, that is within a week, then these flap stria disappear in most of the cases. But if it crosses beyond 1 week, then you'll have to pray to God as well, because many times these stria come again. And this is a case wherein there was post-traumatic dislodgement of flap with flap stria, and the patient came 2 weeks after. There was some amount of epithelial ingrowth as well. So the flap was lifted, the epithelial ingrowth was removed, and once the epithelial ingrowth was scraped off from both sides, it has to be scraped on both sides, both on the stromal bed as well as on the undersurface of the flap. And then you do ironing of the flap, and then you also, once you have done sufficient ironing, then you reposit the flap, debride the epithelium on the front surface as well. Here there is epithelial ingrowth again in the margin, because it was a dislodged flap with epithelial ingrowth, so it was removed. There is some epithelium here which will be cut later. It was removed later. And then the front surface, the anterior epithelium is also scraped off, ironed. And then you hydrate it. Hydrate it nicely so that it swells. The flap striae disappears. And you put a bandage contact lens later. Now if, as you can see now, I'm debriding the epithelium. So what happens that if you have debrided the epithelium and you hydrate on the front surface as well, then the stroma imbibes the fluid and the flap straightens up. And in majority of cases it works, but definitely not in 100% cases. Particularly it depends on the duration of the occurrence of flap striae. Now this was one case. Fortunately there is no flap striae after doing all this procedure. The same case in which the procedure was done. Now if you have done a radial keratotomy, it's an old video, the only one with pie in the flap that we have, so I'm showing it. If you have a radial keratotomy done and then you are doing LASIK, then you have the risk of having pie in the flap. This is the pie in the flap. Basically because of the opening up of the incisions, you get a pie in the flap. So what you can do is you can, if you have created the full flap, then you can do ablation, reposit the flap, and just see that the edges are well opposed to each other so that there's no epithelial ingrowth. Put a bandage contact lens and hope for the best. If you have a torn hinge, see like this, you can have a torn hinge. So once again, what you can do is that you can lift the flap, do the LASIK, and then reposit the flap, and then have to align these edges very nicely. Once again, there is a risk of epithelial ingrowth in these cases. So you have to be really careful in such situations. Do the LASIK, reposit the flap, and then see to it that you oppose the two cut edges nicely. Now, epithelial ingrowth, once again, as I said, that it can occur because of dislodgement of the flap, or in re-LASIKs, there's more risk because you have to lift the flap after, say, 6 months or 1 year or 2 years, 3 years. In that case, there is chance of epithelium getting implanted in the undersurface of the flap. Now, if you have epithelial ingrowth, as I showed in earlier cases, you have to lift it up and scrape off the epithelium. But sometimes what happens that you can have a flap melting like this. Now, this is a flap melt because of epithelial ingrowth. Now, this is our patient only, not the LASIK was done somewhere, but the patient came with epithelial ingrowth to us. It was in the periphery. We thought it's in the periphery. Let's wait for some time. Then there was more proliferation here. We still waited, and then it melted. Now, since it melted and it was irregular, if you lift the flap, scrape off epithelium, reposit it, again there is a chance of epithelial ingrowth. So in such a case, what you can do is that you can remove this flap completely. So you just check the records, what was the thickness of the flap. So in this case, it was 120 micron flap. So the flap was cut and a donor lenticule was fashioned. A donor lenticule of 120 micron thickness was fashioned, and a sutureless anterior lamellar keratoplasty was performed after scraping off the epithelium completely. So the flap has been removed, and a donor lenticule of 120 microns has been placed in position. Now the sutureless anterior lamellar keratoplasty, these flaps stick nicely. It is basically based on the theory that LASIK flap sticks even after free cap. So we can do sutureless anterior lamellar keratoplasty for anterior stromal dystrophies to improve visual acuity. So in this case again, because there was flap melt, donor lenticule was fashioned, and there is hardly any risk of complication in such cases. The only thing is that you have to be very careful in, removing the fluid from the edges. You wait for 3 minutes, can wait for 4 minutes, there's no harm in that. Flap sticks, and then you place a bandage contact lens. In this case, what we normally do, we do SALC in anterior corneal dystrophies, and normally what we do is we'll put little bit of glue on all the edges. So it stays very well in the initial phase, and later on there is enough of support by enough of adhesion that it stays for, if not ever, for very, very long. Now, interface debris can be seen. It can be metallic fragments, it can be oil, it can be lint, all those things, and you have to, in order to prevent that, you can use powder-free gloves. Now, if you have such debris, it's always better to lift it up and remove the debris. And the best thing is that you should examine the patient immediately after LASIK, because you can see the debris immediately. So take the patient, lift it up and remove. If there are very few debris in the periphery, you can leave it like that because it's not going to affect much. Now, corneal perforation is something which is extremely, extremely ominous, very serious, and it has been reported in literature, so that's why I have covered it. So if it's perforated, then you have to terminate the procedure, you have to do a primary repair, and later on maybe you will have to do a keratoplasty. Now, this was basically the complications related to the microkeratoma and the FEMTO flap. Now, with ablation, you can have a decentered ablation, which is very uncommon these days with the current generation LASIK machines. You can have undercorrection or overcorrection, some amount of residual refractive error left, and if that is the case, if the patient does not have ectasia, if the patient is fit for re-LASIK, then what you do is that you have to lift the flap. So you press in the center, and once you press in the center, the edge lifts up, and then you can easily lift up the edge, and then you can do re-LASIK. You have to be very careful while relifting the flap that you don't implant epithelium, because the re-LASIK has an inherent risk of implantation of epithelium and epithelial ingrowth. Then of course we can have regression in very high myopias and hypermetropias, and if you have regression, you can do retreatment. If the patient is not fit for retreatment, you can provide contact lens. Because sometimes you have regression is basically because of either keratocyte hypertrophy or because of ectasia. Now if it's because of hypertrophy, you can go ahead with retreatment, but if it's an ectasia, in that case you may have to give RGP contact lens, which is the best ones that are available currently are the Rose K contact lens, which is the mainstay for treatment. However, if the patient has a post-LASIK ectasia, you can also do, if it is not progressing too much, then we have an option of combining the INTAX procedure or the intracorneal ring segment along with the collagen cross-linking. So this is INTAX, FEMTO second assisted INTAX. So this is the tunnel that has been created. This is the vertical incision. So with a blunt instrument, you just have to open this up. Once you open it, the vertical one, then you have to just open the initial part of the track that has been created by femtosecond laser, because you have to push the segment first, and once it is there, the segment itself keeps separating and goes into the track nicely. So on both sides, the track has been opened up, and then this is the intracorneal ring segment that is being placed on one side. So it's there, now the same being done on the other side. And once it's there, then you just have to put one suture to close this vertical incision. And that is it. Now, many times, unfortunately, I am not showing that video. That part has been edited, in which what we normally do is that we also do a collagen cross-linking. We debride the epithelium, central epithelium, put riboflavin and do an accelerated collagen cross-linking in such cases so that there is no progression of ectasia. Now, dry eye is another complication of LASIK which is seen because of denervation due to flap creation. Now you just have to treat dry eye because it is temporary. Normally what happens that after LASIK there is a study which has shown that the regeneration of nerve takes nearly 4 to 5 years, but 99 or more than 90% of the patients become asymptomatic after 1 year. So the rationale of giving treatment is up to 1 year. If the patient requires even after 1 year, you have to treat dry eye after 1 year, and that can be given by preservative-free lubricants as well as cyclosporin eye drops. Both are very effective and useful in post-LASIK dry eye, which in one survey was found to be causing dissatisfaction in 1 out of 5 individuals. This was a survey conducted to see the patients who were dissatisfied due to LASIK, and 1 out of 5 were dissatisfied because of dry eye. Diffuse lamellar keratitis is something which is an inflammatory thing which can happen in the interface. If it's in the periphery, you can just treat with the steroid drops. But if it's going into the center, you have to lift up the flap and clean it and then reposit the flap and keep the patient on post-operative steroid so as to reduce the inflammation. This is a case of a grade 2 DLK in which steroid treatment was started and it resolved by day 7 to a great extent. This is a case of an infectious crystalline keratopathy after LASIK. This is basically a crystalline keratopathy which usually occurs because of Streptococcus viridans, and this has been reported earlier in cases of lamellar keratoplasty, and this was the report that we had sent after LASIK. So the flap was lifted up and we tried to remove this infiltrate, debride the infiltrate, send it for culture sensitivity. It was found out to be having Streptococcus viridans, sensitive to vancomycin. So after a reasonable amount of this debridement, the flap was reposited and the patient was put on intensive vancomycin eye drops and the ICK resolved. And even on the surface, it was antibiotic was put and the flap was reposited. Infectious keratitis is the most severe and most devastating complication that can happen after LASIK, and any refractive surgeon is really scared because it can happen in any case. More often it happens with PRK procedures. And recently we had a patient of acanthamoeba keratitis after PRK because you debride the epithelium, put a bandage contact lens, so there's more risk. But after LASIK, there is less risk, but still you can have. And if there is infectious keratitis, then you have to treat it as any other infectious keratitis. The most important thing in these cases, which studies have shown and we have also reported, is that the response to treatment is better if we amputate the flap. Now, if the infiltrate is somewhere here in the periphery, you can do a partial amputation here and leave the rest. So what happens, this is the nasal part. So if you remove the temporal part, it still heals up fast and you can manage. But if it is somewhere here, you have to amputate the whole of flap in order to have a good response. Otherwise, many of these patients are very refractory to treatment. And as I said, we have to do microbiological investigations and use intensive fortified antibiotics or any other, depending upon the sensitivity pattern as well. So, in spite of presenting so many complications, I would still say that LASIK is an extremely safe surgery. Now, all these complications were in the percentages of 0.1, 0.01%, and they are very less, but although, because we need to know all these and we have to be careful because it's a cosmetic procedure, and if there is any complication, then in that case, prompt and appropriate management has to be done as early as possible, and it should be shown to the patient as well that you are extremely aggressive in treating so that the patient also doesn't feel that, this complication has not been handled properly, because there are many patients and there are many surgeons who send their patients to us and they keep requesting us that please tell them that we have done the right work because they are after our life and they are demanding this and that. So you have to explain to the patient that even before surgery and at the end of surgery and after having any complication, that these things can happen, and we are trying to do our best to get the best result even after this. Thank you very much.